Hello and welcome to another episode of the CIRS Group podcast. I'm Barbara.
And I'm JC.
And today we are joined by the wonderful Dr. Peg DeTulio. Thank you so much for being here. We're so
Thank
happy to
you for
have you.
inviting me. I'm delighted to be here. Always. Thank you.
And for those of you who don't know, Dr. Peg has been in the CIRS world for a while. She's got tons of experience, especially with complex cases. And that's why we wanted to bring her on today to talk about a topic that I think isn't discussed as much, at least within the CIRS world, is the tick-borne illness side of things. So before we get into it, though Dr. Peg is a doctor, this should not be considered medical advice. Always consult your own practitioner for any choices you make medically.
And Dr. Peg, you recently did an amazing interview with Nutrition with Judy Cho over on her channel. So we'll refer people over there. Pause this video, keep the tab open, but pause this video, go watch that, and definitely come back to this one if you're interested in learning more about tick-borne and Lyme. So tick-borne illnesses, I think, is just this huge Pandora's box. I know when I was first looking into CIRS and someone mentioned it to me, I kind of like peeked in the CIRS box and I was like, oh, that's overwhelming. No, thank you. And it took me a little while to get into it. And now that I'm fully in the CIRS box, I'm finding that there's more boxes like actinomycetes and this one, the tick-borne illness box, which full disclosure, I think I need to peek in this box. So I'm very excited to have this conversation today. But I think the first thing we kind of wanted to get a better understanding of is if you could please explain the difference between like tick-borne illness and Lyme, because I've kind of heard of Lyme a lot more than I have of any other tick-borne illness. And I think people kind of think it's the same thing.
Sure. Yes. And so I want to thank you again for having me. And I also want to just preface my comments by saying I have a lot of experience in this arena as a primary care provider for 28 years in an endemic area, aside from even my environmental studies. So I had to deal with this issue early on. And if you had been interviewing me years ago, the way I approached tick-borne illness, very different than today. And there's some reasons for that. And I believe that over time and experience, we grow, we learn what's better, right? So, but you need to know, and your audience needs to know, that there are many people that would not agree with my approach, So this is what I will talk about today is based on my experience and my knowledge of treating tick-borne illnesses, diagnosing and treating, and then the audience can decide, what matches with them best. They might be hearing of something else. But to your question about Lyme versus the global kind of umbrella category of tick-borne infections, basically we know that ticks are like little stealth bombers, right? They're tiny, microscopic, right? So small that people can get bit often and not even know they were bit because the tick falls off before they even notice that a tick is there. And they have the capability of carrying multiple infections. So we've historically called them co-infections. I'm not sure that terminology is the best, but that's what you hear said. Lyme disease is a very specific infection from a very specific atypical bacteria, and that's Borrelia. But ticks can carry other infections. You've heard these before, I'm sure. People in your audience have heard Bartonella, Babesia, Mycoplasma pneumoniae, Anaplasma. So, and there's a lot of discussion about viruses, which I won't really get into, in terms of ticks. We know that mosquitoes can cause some very dangerous viruses. So often people will refer to Lyme disease they're really referring to the more global issue of tick-borne infection, right? But Lyme is a very distinct infection, different from these others. And we do have some characteristic symptoms for some of the co-infections that help us to sift that out, but many of the symptoms are the same.
And kind of on that note, what what are the symptoms, I guess? What should people be looking out for, especially those of our listeners who have CIRS and they're not sure if maybe it is caused by a tick in the beginning, and maybe they have mold exposure too. They're not totally sure. What should patients be looking out for to see if maybe they might be a candidate to go down this rabbit hole?
So here's the Pandora's box, right? This whole issue of multi-system, multi-symptom symptoms. And just as with CIRS, we have characteristic symptom profiles. There are people that have symptoms with CIRS that are not on that, on those these symptom clusters, right? They're unique to those people. They weren't prevalent enough to make it onto the symptom clusters, but they're still related to their CIRS. And so the symptoms of tick-borne illness often mimic the symptoms for CIRS. And here's where, the dilemma in the population of clinicians that are exclusive to treating tick-borne illness, but don't know about CIRS or aren't schooled in it, will often use symptoms as a basis for diagnosing tick-borne illness. Not, a little bit slippery,
Yeah.
right? Because you've got this other category. So in what we really believe to be true in treating CIRS in people who could have a tick-borne illness is that you really need to address the mold issue first. And this basically is central concept of immune dysregulation in CIRS. So think of an organization whose managers are all confused and disoriented. How can that organization do anything effectual, right? They're just complete. Think of chaos. When you think about CIRS, that's what we're dealing with. We're dealing with an immune system in chaos, very disorganized. And so to ask that immune system to be a partner in treating an atypical infection now, atypical, right? Because they're all atypical, the ones we just mentioned and talked about, is somewhat foolish, right? How can the immune system be a partner? If you've ever studied traditional Chinese medicine, which has kept the Asian population healthy in Asia for centuries, fundamental to traditional Chinese medicine is that the immune system is in charge. And if we just had a strong immune system, everything would flow from there. And I think that is really a central tenet that is important for anyone with CIRS to understand. So what often we find is that when you treat the CIRS, you always have, so we work off differential lists, clinicians work off differentials. And on the differential list is always tick-borne illness for someone with CIRS, right? Because they have all these symptoms. And we kind of look and see, well, what's going to happen when we treat the CIRS? When we organize that immune system? If in the simplest of cases, all right, so you folks know these cases get very complicated with Ehlers-Danlos and mast cell activation, all these other things, right, that are kind of triggered from. But take the simplest of case, a person who just has the genetics for poor clearance of mold, is living or working in a water damaged building and acquires a CIRS situation. What we would expect from that is that out of the bad environment, on a binder, well, call it cholestyramine, that person's going to go along a trajectory of recovery that is predictable, right? They're going to get better. And you're going to say, go celebrate, you're better, good, live your life, don't go in water damaged buildings, or all the kind of advice we give people, how to manage that genetic problem, how to make choices. But that person's symptoms resolve. Now take another case where a person has CIRS, and we really don't know what's happening with if they have an underlying infection. It's on the list of possibilities. Now they're out of their moldy environment and they're improving. But there are some symptoms that don't resolve. Number one, that would be a red flag. It doesn't mean they have tick-borne illness. So an example of that is if the patient has knee pain at baseline, and we know that Lyme, for example, has a proclivity for the synovium in the knees. So knee pain can be very, common in Borrelia. And that knee pain has not changed. The person's out of their environment. They're doing everything. Other things are improving. Well, that doesn't mean they have tick-borne illness like Lyme disease. What it means is the clinician has to look at that symptom and go back to the differential list and say, what might be causing that knee pain? Has the person been worked up by their primary care? Have they had an x-ray? Do we know? Is this arthritis? Is this something else, right? So you have to do due diligence and look at those residual symptoms and say, maybe this isn't related to anything that I'm treating. Maybe this is just something they have. But it would be a red flag, certainly, if the person is improving and many symptoms are improving, but those symptoms that aren't improving, you need to look at. Now, it's fairly common in people who do have underlying tick-borne illness that once they get to a certain point in their CIRS recovery, things start to happen that tell the clinician that the likelihood is that there's something else there. What are those things? Well, they're Western blot, which I do every time I do labs. If someone is insured and has coverage for labs, and I will do a Western blot every single time. And the reason for that is if as you're getting better and your immune system is getting better, you're going to get a better response on an antibody test. You're going to see more antibodies reported out on that Western blot. And so that sometimes is a clue. If you see a 39 or a 23 band show up that hadn't showed up before, you can tell the patient with confidence that they have been exposed to Borrelia. You're not diagnosing them with Lyme yet, but those are very Lyme-specific antibody bands. There's nothing else in the universe that's going to cause that to be present. So you can say to the patient, at least I know by that finding that you were exposed. We have to do more work to figure this out. C3A can be a good marker for the immune system now seeing an infection it didn't see before. Typically in CIRS, C3A is below normal. Often it's suppressed. The production of C3A, this is a very specific marker for bacteria engagement with the immune system. Now, as you're fixing the CIRS, we expect the C3A to at least get into range, in the lower part of the range. And then we say, good, immune system's doing better. But what happens if the C3A shoots up to 350 and it was only 55? Well, that is a red flag. That is a warning shot that there's something going on. It's not specific to a particular bacteria. It could be mycoplasma. It could be Borrelia. But again, it gives you the sense that as the CIRS is being corrected, we're now seeing the evolution of new findings that help to say you need to do more work in this area.
I kind of liken the investigation into tick-borne illness kind of like a house remediation, in the sense that you don't go in, get a hurts me too score. Oh, it's a good score, or it's a meh score. Like, you don't just take that. You go, okay, now we've got to dig further, and now you've got to get thermal cameras and then also moisture readers, and you got to dig, crawl into the crawl space, all this other stuff. It sounds like if you suspect Lyme or tick-borne illness, you just kind of like start to piece the pieces together a little bit, or put the puzzle pieces together. That's what I meant. And it's all contextual. There's no one test that definitively will say it necessarily, right? Or what is the testing process?
So testing is a quagmire. I think everyone already knows that. I'm not telling you anything new. if we only had very sensitive and specific testing, the world would be so much easier to manage in relationship to these infections, right? So we're dealing in an imperfect world with testing. In some cases, it's quite clear. So for acute Lyme, the traditional CDC criteria of 2 IgM antibodies being elevated. So in the simple situation of, I got a tick bite two weeks ago, and as I sit here, I have flu-like symptoms and a bullseye rash. You don't need a blood test to tell you have Lyme disease, right? It's diagnostic.
Right.
And so, and ultimately, the testing would probably show that if you did the antibody testing at that point. Or like my patient on Long Island, who had no risk factors for tick-borne illness other than living on Long Island. It's an endemic area, right? Who had 2 completely negative Western blots on her first 2 sets of lab outside of her moldy environment. Now, okay, she was getting better from her CIRS. She had a subnormal C3A, 2 negative Western blots, no antibodies at all showed up on those, none. And then on her 3rd set of labs, she had 5 IgG antibodies on the Western blot and a C3A that was over 400.
Wow.
That's a classic case of, it was there all along, and the immune system just couldn't see it and wasn't organized enough to make antibodies in order for an antibody test to be able to tell us. Testing, there are other methods of testing. Here's the challenge. You have a test that looks at some DNA, and that might say that there are particles that are present. Does that correlate to illness, or is that just exposure, right? And so the whole issue of validation studies, when you have a test, the ideal is to be able to do the research where you have the patient with the abnormal marker that you're looking at and symptoms that you're associating with this illness, that they're treated, and then that data is collected and now things are negative again. But it's expensive to do this kind of work. And so a lot of times the labs just are not doing validation studies. So it still leaves us with a bit of a question about, how much faith we can put into the testing, right? So I think that we do the best we can. I typically will use the traditional LabCorp Quest, even though they are not, particularly good at showing infections. They're missing a couple of very specific bands, which is a long story of politics and medicine. But 31 and 34, those 2 antibody bands are not included on the LabCorp or Quest testing. Medical diagnostics labs in New Jersey and Stony Brook lab always included them. So you had to kind of go off the track with these other labs to be able to see these more specific antibody bands. And of course, IGeneX in California includes those bands in their testing. But sometimes the traditional testing can give us important information. And so that's usually where I start, because for most people that's covered by their insurance, right? If I suspect, because of that whole symptom review, and now I'm thinking that there's something there. An example of that would be, we know that night sweats can occur with mold illness, right? Night sweats are on the symptom cluster list. However, night sweats are one of the more common symptoms associated with babesia, right? So if the patient has night sweats that do not resolve, right? They're out of their mold. They're on their binder. They shouldn't, unless it's a perimenopausal female. And then, again, we are faced with many challenges in trying to sift through all this stuff.
Right.
But So say it's a man. We'll make it easy.
There you go.
So this male patient is still having night sweats, despite being in a good environment. And on top of that, he has air hunger. Air hunger, common symptom, can be associated with mold, but we're talking about someone who is now going through their program. And now he's still having this, air hunger is sighing at rest, basically sitting here and just needing to take a deep breath. I asked a 9-year-old little girl years ago, my primary care practice, her parents said she would sit in between them on the couch and she would sigh the entire time. And so I said, your parents tell me you sigh a lot. You take these deep breaths when you're not doing any exercise. Why do you do that? And she said, I feel like my lungs have come up and I need to push them down again. That was how she described that air hunger symptom, but it's very real. So now your male patient is having night sweats and air hunger. I do a Babesia test at LabCorp or Quest and I get nothing. What am I going to do? It's very suspicious for that infection. You have to go to some other labs, to look at that. Sometimes what I will do is challenge with an herb before the testing. So say I have someone who's really resource limited and they're not going to be able to pay for IGeNIX or another test. They just aren't going to be able to. But they could pay for an herb that treats Babesia. It's a relative do no harm. Herbs are relative do no harm, right?
Sure.
And so they can titrate up. Number one, if they do that, I can see what happens when they do that. I can see what happens to their symptoms. Do they have a kind of a Herxheimer reaction? Is it a ho-hum? Nothing happens? But I can tell a lot by their reaction to the herb. And the other thing is, once you start to treat it, it's the first shot across the bow. And so the immune system is forced to become engaged on some level. So sometimes you can get a better yield on your antibody testing if you start to do some treatment ahead of time and wake up the sleeping giant a bit. So that can be another strategy if someone is very resource limited to try to get a better handle and get a positive test.
You mentioned risk factors for tick-borne illness and being in an endemic area. Are there any other specific risk factors that someone might want to just kind of clock to see if they might be at risk for tick-borne?
So location is certainly a big one, right? And occupation, recreation, big ones, if you're a landscaper, much more risk than if you're a computer programmer full-time, right? Especially if the computer programmer doesn't recreate outdoors, So you have to look at the exposure potential. And of course, then the area with which, the East and West Coasts are heavily, high occurrence areas. If you talk to Dr. Dorninger and talk about Colorado, he would say not much here. And that's true. It's not a high percentage state. Doesn't mean you can't get it. And as people move around, that is going to equalize a little bit more. But for now, it would be considered a lower risk area to live. So the other things, of course, are what's going on with the immune system, because we already talked about that, right? And so so many people have no idea that their immune system is dysregulated, right? They don't really know that. A lot of some of my work with my primary care practice before I was both feet in the CIRS world was querying about exposure, meaning at a well visit for an adult, I might say, is there a musty smell in your basement? As part of my history and review of symptoms. And if they said yes, I would say, well, that could mean you have mold and that can be an issue. And they would say, oh, everybody has a musty smell because everyone thinks that's okay. But anyway, I would offer them some testing. I would say, you have these symptoms. They're not disabling you. You tell me you're a little bit tired, but we know that maybe you're not sleeping as well. You have these, you've got some achiness, you've got these things. Let's just, if you want, I can just run some markers and we can see, does it look like there's anything going on? Well, what my findings at that point were the abnormal markers preceded the full expression of the illness often. In other words, these people may not have even met the full diagnostic criteria for CIRS looking at symptom profiles. And yet they had exposure and they had abnormal markers already. And so when you look at the number in the population of people that have immune dysregulation, they get bit by a tick, their immune system isn't going to be able to handle this well. And I really truly believe that this is why we see the tick-borne infections so commonly in the CIRS population, because they get that bite and the immune system isn't organized enough to take care of it. There are plenty of people who get bit by ticks that don't get Lyme disease or one of these others. And the Lyme, I can tell you on it, because again, in primary care, people would ask for Lyme testing. They often would show up with a 23 or 39 band, just what I mentioned before. And I would say, gee, these are healthy. These are people that have no evidence of illness. And I would say, well, you certainly had exposure to Borrelia. At least one of those spirochetes transferred because you have this marker that says your immune system saw it before. But they're not sick, and they hadn't been sick. So we know that if somebody has an immune system that's well oiled and organized, they can have that tick bite. Some Borrelia can go across, and they may never, their immune system may take care of it fine.
Wow.
Yeah, but so immunodysregulation, and then those people that have immunodeficiency, we don't routinely test for this in mainstream medicine, right? Primary care, I don't know, I don't do IgAs and IgGs and thing unless someone's sick, and then you're working them up. But we're not screening people for immune deficiency disorders, and yet they certainly could have deficiencies. So, you know, this would be another area where a person might have more risk.
You mentioned that Lyme or tick-borne is very prevalent, I think you said, in the CIRS community. Do you have an idea of how common it is for CIRS patients?
So no, that's the simple answer is no. If you were to, so I don't think a lot of people are doing the testing, so there's not a lot of data. If I simply went by without analyzing any data or doing any kind of analysis, but just my sense of my own practice of CIRS patients and tick-borne illness, it easily could be 25%, between 25 and 50%, somewhere in there. I think it is that common.
Given the proclivity of tick-borne illness to hide, I know that quite a few of our members do get tests like the GENIE or the NeuroQuant, and there seem to be some evidence on those tests that can show at least Lyme for NeuroQuant, right? If a member has gotten one of those tests and nothing about Lyme or any tick-borne illness has come up, can they safely rule it out, or should they still dig deeper if the other markers are in place? What would be your thoughts on that?
Yeah, so these are great tools, but as tools go, right? When we talk about Ermine and Hertz, me being a tool, not diagnostic, right? It's kind of in the same arena as that. They're incredibly good tools and important if one can get them, but I would not rule out. And so, for example, for GENIE, the Lyme section, what we know about that is if the person is naive to treatment for Lyme, then that can be evidenced in that section. But here's the problem with some folks. any antibiotics taken could be affecting that. So say you have the person with a chronic sinusitis. They're 14 days, they're repeatedly on antibiotics before that GENIE is done. That they could have just as easily been treated for Lyme with those antibiotics, right? So that can cause some challenges, if somebody has been on these antibiotics prior to the testing. In terms of the NeuroQuant, once the general morphometry report is available and you put that through surviving mold and we get this scoring. So the scoring for Lyme, of course, is maximum number of points is 4, 3 or 4 in the Lyme category is suggestive that the changes that are evidence on that NeuroQuant are consistent with changes that are seen in Lyme disease, right? So that's it's a pretty powerful tool when you have a 3 or a 4. And it would just mean that you do your work, though. You still have to do the other work.
Right.
And what happens if you have a 2? Borderline, right? For Lyme score. So does that mean there's no chance? Probably not. No, because for that individual, for whatever, they could have been on a lot of supplements ahead of time, a lot of, quercetin and things to reduce inflammation, fish oil, all these different things. They could have effectively treated some of that inflammatory effect, so you're not getting the full effect. So the basic message is they are wonderful, wonderful tools, and they can lead you in the right direction. But you still have to do due diligence with other testing.
Makes sense.
So we've talked about kind of how someone might understand if they should look down the Lyme tick-borne rabbit hole. But once they understand that maybe they need to address it, how treatable is Lyme and other tick-borne illnesses? And how does it impact their overall timeline from healing from CIRS compared to like a just CIRS patient?
Yeah, so another loaded question, JC, right?
They're our favorite.
Yeah, so treatment, and here is where I will say there's a lot of varying opinions about it. There are people that espouse very aggressive, multi-antibiotic treatments and other things that are not in their feeling is it necessary to take care of the problem. And then, as with everything in the world, we have a spectrum, correct? So we have history. Again, I'll revert back to mentioning the traditional Chinese medicine, Ayurvedic medicine, right? And a long tradition in the United States of herbal treatments for infections. And I think I'm confident to say that those modalities have been successful in treating a lot of people. And, I've done 2 years of herbal training, and I understand, from my teachers and reading, Stephen Buhner's work. Stephen Buhner is no longer with us, but he was one of the master herbalists in the country, a prolific writer. Anyone who is interested in looking at herbal treatments for tick-borne illnesses, that was his expertise, and deals with all the co-infections and the herbs, and very research-based. He was really a scientist, and he was not cavalier. So now I'll take it kind of back. So we have these different approaches. I'm going to go back to what I said earlier. If you had done this interview with me 20 years ago, the way I would have talked about treatment would have been very different, because that 20 years ago was my understanding anything about CIRS and mold. It wasn't even on the radar for me at that point. I still was in that arena of, you just have to, treat with aggressive antibiotics, and you need aggressive biofilm busters, prescription ones. My experience was that is not only not a do no harm, right? Because what I said was we always want to start from there if we can. I began to see many people coming that had been on long-term antibiotics, and the challenge of the dysbiosis and the gut, and remembering that your gut is your second brain, right? Common thought.
Yeah.
And right. So if you create all these issues with the gut, now you're even adding more to your brain challenges, which people already had. So why not take a more conservative, sometimes longer approach? That is to your point. What kind of time frame are we talking about? And I would say to people, listen, if it takes a long time, you doing some herbs every day and rotating some herbs and doing some of that, but in the meantime, you're feeling well and you're feeling better, then what is really the downside of that? There are many illnesses that we have to treat longer. And so, and I think that, I always talk to patients about the tortoise and the hare, and who won the race ultimately, right? The tortoise, going slow and just being more thoughtful about the way to approach it. So depending on the number of infections, if it's just a straightforward Lyme situation, if it has been around a long time, right? But so say we're just realizing that this Lyme infection is there, but we think maybe it could have been obtained 10 or 20 years ago. So now we are dealing with an atypical infection that hides in different forms, that it gets into cysts, right? Makes cysts around itself. It can just lay dormant. It gets under biofilms, the same as any bacteria, mark-ons, right? Biofilms, they're a common theme in infectious disease. And they, so you have to kind of give time, something in the bloodstream all the time. So as these things come out, use your enzymes, lumbrokinase, serrapeptase, rather than using pharmaceuticals that break biofilm. We have good agents that break biofilm that are not going to have the side effects of a pharmaceutical. But everything has to be timed and staged so that, you can do things methodically. And I do want to remind people that I'll use Lyme as an example. You have to remember the goal of treatment. The goal of treatment with Lyme is not the same goal of treatment if you had Mycoplasma pneumonia, right? The goal of treatment for pneumonia would be that all the infection in the lung is gone, right? That's the goal of treatment. Do we really think we're going to eradicate and remove every spirochete in the body, behind every biofilm, in every cyst? Is that the goal of treatment? No, that'd be silly, right? Because there are many that stay hidden, but that doesn't have to be scary, because once you get the burden down, your immune system now is really organized. One of those spirochetes comes out of their cyst or comes out of their biofilm, gets into the bloodstream. What's going to happen? The immune system is going to do its job, right? It's going to do its job. It's going to take care of that. And the only time you really get into a situation where you might need some help, once you've gotten the burden down, is when what happens? Somebody has a stressful life event. Somebody dies, they have to move, they lose their job. There's some kind of life stress. What happens with that? It's all about the immune system. The immune system takes a vacation. It takes a dip. ACTH levels drop precipitously in acute stress. So then you might have, I call them the unruly visitors. And I don't mean to make light of important things, but we can't be fearful. People can't be fearful of another thing. There's too much fear already. You just have to put it in perspective. So the immune system will come out and it will, if it's suppressed, the unruly visitors will start to misbehave. So sometimes during periods of stress, a person will say, my Lyme symptoms are back. Well, that makes sense, doesn't it? My Lyme symptoms are back because the immune system is not quite able to do its job. So that's when you can give some additional herbal help, whatever, and until that stress is dealt with. So it's really about burden and then allowing the immune system to do its own job really well.
Amazing. Well, thank you so much for talking to us all about tick-borne illnesses. I know that this is something that you've championed the awareness of for quite a while now. And I know that people in the CIRS community would be so excited to help you spread that awareness. So is there anything in particular they can do to just help spread the word?
So are we talking about the CIRS clinicians or the CIRS, the people experiencing CIRS? And some of those are both categories.
Yeah, both for sure.
Yeah. Yeah. Well, I think that we, from a clinician standpoint, and I will be doing case reports and case presentations in the fall and September in an effort to try to increase awareness. And I know that there will be a lot of clinicians in the surviving mole community that will be accessing that information. And it's about increasing awareness. And from a consumer standpoint, if I'm the person with the CIRS and question of tick-borne illness, as with anything today, consumers need to be advocates for themselves, right? And so knowing that these things are possibilities, you need to ask the questions, of your clinical treaters and say, I'm interested in looking at this area a little more. And I think by raising that issue, if a clinician is not comfortable in that arena, and that might be the case, then the obligation would be to refer to somebody who knows a little bit more about it.
Was there anything else you wanted to add, Dr. Peg, before we wrap up?
No, as I say, there's a lot that could have been said that I didn't say, but it's a big topic, so I think we just have to keep regularly bringing the awareness up, right? And that will work.
Yeah.
That will work. And I want to compliment you too on the work that you do. It's amazing. And I've been in this arena 14 years in the surviving mole camp. So there was, we didn't have a Barbara and JC back then, when I first started. And so it makes such a difference for patients and people to get information and get the support that you offer. I can't tell you, it's changed the game really. So keep up the good work, I hope, because you'll keep doing it.
Yeah, no, thank you so much. Well, I mean, we wouldn't be here without all the work that you guys have done to get it to where it is now. And it's crazy how fast it's all evolved. But if there's any small thing we can do to repay the gift that I know JC and I feel like we've been given to know what our diagnosis is and to be able to treat it and give back in whatever way. Thank you for saying that.
Thank you so much for joining us today. And if you, our listeners, are looking for more resources and support on your CIRS journey, you can join us over at theCIRSgroup.com.
We'll see you there.